Okay, it is.
Okay.
We are going to we're going to round up people on the outside and get them all in here, and we'll be starting in 2 minutes. Okay, if you can please be seated. Okay, and we'll go ahead and get started here. I think he's adjusting the sound on the mics. Okay. Very good. Good afternoon. First of all, a little housekeeping. The restrooms are just outside the double doors and to the left. So if you need to utilize them, they're just right out there. Secondly, if there are folks back home that are on your staff and they wish to hear what's being said today, we are webcasting this off of the campus today, and the address, the internet address, is in your packet. Also, it'll take a couple of days, I guess, to get posted, but early next week, we'll run the video, unedited. We'll run the video on our website, and you can go there, hit the link, and if there's something you want to clarify, if it was said or not, it'll be available to you through that electronic media. Let me start off by introducing myself. I am Dr. Kirk Calhoun. I'm president of the University of Texas Health Science Center. We are the academic health science center for Northeast Texas. On behalf of our nearly 900 faculty and employees, please let me welcome you to our Tyler campus and to our biomedical research building, where we do early stage medical research, we do new drug development, and we teach the next generation of medical scientists. I am a physician, and I have been practicing medicine and teaching new young doctors for 33 years. Many of our graduates are treating patients in your communities and working in your hospitals across Northeast Texas. I chair the National Association of Public Hospitals and Health Systems, the advocacy group for publicly funded hospitals across the entire nation. My professional life is spent writing about, teaching about, and talking to government leaders about issues like Medicaid, DISH, UPL, medical education funding, and rural health. We run a hospital on our campus. It is a hospital that is very, very, very dependent on Medicaid funding. I feel honored to be asked to serve on the Texas 1115 Executive Committee, 1115 Waiver Executive Committee, and to work with the dedicated people at Texas Health and Human Services. We have representatives from the Texas Health and Human Services Commission and the Department of State Health Services here to lead a discussion with you on where the waiver is going and tell us the impact of the waiver on health care delivery, and very importantly, to share with us how the money is to flow to our region, for our hospitals, for our medical care, and for our mental health services. Our guests today are Maureen Milligan, Deputy Director for Quality and Cost Containment at the Texas Health and Human Services Commission, and Jan Mayberry with the County Indigent Care Program at the Department of State Health Services. And I will turn the meeting over now to Ms. Milligan.
Well, good afternoon, everyone. My name is Maureen Milligan, and thank you for being here. It's a pleasure to be here. I want to thank Dr. Calhoun and Kimberly and Daniel and everyone else here for hosting the event for us today. So we look forward to a lot of discussion and questions. So we'll walk through a document with y'all. Some of you might have seen some components of it, but we really want to have a conversation and answer any questions that you have. And if we can't answer them now, take them back and just tee them up for questions that need to be answered. So appreciate that. Jen Mayberry is also with us. She's the director for the County Indigent Healthcare Program. in Texas, and so she plays a key role in understanding the waiver. She's been working with us on the waiver in our rural outreach since about September, before the waiver was approved while we were in negotiations. So she brings a lot of information about county impacts and how this can work in rural Texas, so appreciate that. So anyway, so thank you for being here. Let's go ahead and just work our way through the PowerPoint and get into the conversation. So brief review of the waiver. Why do we need a waiver? So basically, here's the deal. Before the last legislative session, we had a Medicaid budget issue, a state budget issue, and so the legislature directed the commission to go ahead and expand managed care. So we have a Medicaid program that covers, I think, about over 3 million. It's about $24 billion program in Texas. But most of it is in managed care, but there was a significant portion that was still done under fee-for-service, in particular South Texas and rural Texas. And so the legislature wanted us to do Medicaid managed care statewide to save funds and improve quality. But here was the deal. There's a federal regulation related to a hospital funding program. So here's the hospital funding program. It's called the UPL program, Upper Payment Limit. And basically the UPL program provides funding for hospitals between what Medicaid would actually pays them and what Medicare would have paid them. So it provides a significant amount of money to hospitals in this UPL program. It's about $2.8 billion a year. So that's a lot of money, significant amount of money. So what's the deal? Why do we have to do this? Because the federal regulations in the Centers for Medicare and Medicaid Services are such that the feds interpret them so that if a state moves from fee-for-service Medicaid to managed care, then the hospitals that are now in managed care can no longer get this UPL payment. Can't have both. Federal interpretation of the regulations. Can't both have managed care clients and those clients generate the UPL payment. So the state, we did an analysis and we looked to lose about $1 billion for hospitals. So hospitals said that is not going to fly. We agreed, it's a critical funding component for hospitals. Couldn't do it. Went to the federal government, our executive commissioner, and said, how can we move forward? It's a huge policy issue for Texas. And they said, the only way you can move forward is one of these have your cake and eat it too. Couldn't both do managed care and keep the money. And they said the only way you can do both is to do this waiver. And the waiver is a technical waiver of Social Security Act that allows the state to do some creative things. And so the Fed said, look, do a waiver. We'll waive some of the requirements that would otherwise apply and prohibit this. And under this, we'll negotiate how this would work. You can expand managed care statewide, which we did just about 3 weeks ago on the 1st of March, and so achieve that legislative direction. And we were able to keep the $2.8 billion a year in UPL payments that the legislature also, by the way, directed the commission to do. So they were saying, look, you have to do these two things at the same time. And so the waiver achieves that. But the federal government also has some other requirements in the waiver and also some other opportunities. So that's why we had to do a waiver. It's not just we were cooking up some ideas. It was we really had to do them to achieve two divergent directions from the legislature in the last session. So managed care expansion and the hospital financing component. Now, the waiver is an agreement with the federal government, and it lasts for 5 years. They call it a demonstration waiver. So the feds allow it because we tell them, look, we're going to try something different in Medicaid. We're going to try, in this case, we're going to transform the system. We want to improve the quality. We want to improve access to care. We want to improve cost effectiveness. And we want to improve collaboration in the healthcare system around the state. So those are the 4 key goals for the program. And so it lasts for 5 years. So brief review, this is a little bit on the financing, and the point I guess I want to make here is that this UPL program, the $2.8 billion a year, that's financed, like all Medicaid is financed with a state-fed split. So not to get too technical, but 40% of Medicaid costs are paid by the state or local entities. 60% is paid by the Fed. So every $100 we spend in the Medicaid program, 60 is financed by the feds. The other 40 is financed through state revenues or local contributions. This is important for the following reason. I'll try to be really quick on this one, but there's 3 kinds of Medicaid funding a hospital would get. Your claims funding, so I break my leg, go to the hospital, boom, I get a claim for my care under Medicaid. You get that money, and that's based on me coming to the hospital with a claim. Hospitals can also get disproportionate share or DISH funding, right, that $1.6 or so billion a year statewide. And that funding is a little bit different, and for that funding, the state share, the local share, the 40% is actually put up by governmental entities, largely public hospitals and hospital districts. In my broken leg claim, Medicaid, that's paid by state appropriations through general revenue. So that's a difference. In this UPL program that we're really focused on here, the 40% is put up, again, by hospital districts or local governmental entities. So it's a little bit of it's actually an important point because we'll talk about some of the financing a little bit later. So that's that first point there, is to talk about the financing of the 60-40 split. Now, public hospitals in the UPL program historically can provide for their own UPL payments. So governmental entities, public entities can identify funding and say, here's the 40% of the cost. And they do that for the UPL program. They do that for the DISH program. Private hospitals cannot provide the UPL match. It's just the nature of the federal regulations about who can provide the state match for the program. But public hospitals or local entities, counties, can provide the match for private UPL payments, and this has happened historically. So counties have done that, and nearly all of the large public hospitals have done that, and then they've developed relationships with private hospitals in the private UPL program. And that's important because the waiver really takes that skeleton of the UPL program and transforms it. But we start with that kind of structure of program that yesterday or last year was at about $2.8 billion. That's about 40% funded from hospital districts, and that's 60% funded at the federal level in general. So I don't know if I said the 29 billion. I don't think I said the 29 billion number yet, but let's talk about that for a minute. So remember I said about $2.8 billion a year is in this UPL program, and that's why it was so important to maintain that funding, and that's why the legislature directed the commissioner to do that. So if we were going to maintain the funding of $2.8 billion for 5 years, you'd think, okay, it's about $3 billion a year, 5 years. $15 billion is what we'd need to maintain for the hospitals to have access to. And under the waiver, what was negotiated was $29 billion over 5 years. And so it's a significant increase in the amount of money that's available. So what does this all mean? Well, here's how it changes under the waiver. Is that the funding that has historically flown through these UPL programs and UPL methodologies will change. There's a 1-year transition period so that the funding will pretty much go as it has in the past on the UPL program. And that 1-year transition period will end in October of 2012. And then the funds flow through these two pools. So the only way a hospital that has gotten UPL or a hospital that wants to take advantage of these funds can access the funds is by accessing them through one of these two pools of funds. What do I mean by that? Think of these two as lines of credit from the federal government with a dollar amount associated with them. So it's about $3 billion each a year, just in general. We'll see the actual numbers in a little bit. So think about the federal share of $3 billion a year. So that would be $3 billion. I'm saying about $1.8 billion in federal money available for uncompensated care and for these incentive payments. And so to access the money, you have to do a couple things. One, you have to bring your state share, your local government share, your county share. You have to have some government funding share, the 40%, to pull down that $1.8 billion in federal. You have to have the IGT, intergovernmental transfer. Then you have to meet the criteria for whatever the program is. So 2 programs. Let me see. Let me go back, actually. So under the uncompensated care pool, here's how this would work. Is starting October of 2012, a hospital could access these funds when they submit a report to the state that identifies or outlines their uncompensated care costs. And that would be the cost for providing care to people who don't have insurance, and also this thing that we call Medicaid shortfall. So the cost for people who don't have insurance and the Medicaid shortfall. And the Medicaid shortfall is this. In Medicaid, your costs are, say, $100, and the Medicaid program, this is my broken leg claim Medicaid program now, pays about $56. So Medicaid pays about 56% of the actual Medicaid costs. So the difference between what Medicaid actually costs a program and what we actually pay, Medicaid shortfall. Your shortfall plus your uncompensated care costs at a hospital, you put that together, and then there's some additional funds you can draw down for. But let's just stick with the big picture for now. That'd be your uncompensated care costs. Fill that out in documentation, send that to the state, and you have to have some source of your state match, that 40%, and then you'd be eligible for pulling down the uncompensated care pool funds. The other pot of money, the kind of ballparky $1.8 billion in federal funds, the line of credit, is related to this delivery system reform incentive payment pool. And for now, just at a high level, those are funds that the federal government made available really to transform the system. So what they're saying is lots of uncompensated care in Texas, and we said that's right, that's why we needed to maintain this UPL money because it really helped with that. They're saying we don't just want to pour more money into that, we want you to transform the system so that you're being more effective, you're increasing the quality, you're using your creativity in Texas that we know you guys have to figure out additional innovative and different ways of providing increased access in Texas. So some of you may not like that phrase, but really it's good here, is that, that bending the curve thing. So, the healthcare cost trends are going here. It doesn't mean that they're going to start going down, but maybe the slope bends just a little bit if you can figure out some innovative ways to bend that trend. So those are the two pools under the waiver. Current status, this is actually kind of old news now. The waiver was approved December 12th. We're in that one-year transition payment that I mentioned briefly, so that goes through September of 2012. That is that hospitals continue pretty much to receive their UPL funds as they have in the past. And then effective 2012, payments to hospitals would only apply under these two pools. That'd be the only way that hospitals could pull down funding. So impact on local entities. And you know what, Jan? Let me ask you to walk through these, can I? I'm kind of hitting you cold on this, but since Jan is our county indigent healthcare person and our local expert, let me ask her to walk through these local impact slides.
Is this going? Okay. I think, let me just preface this to say that when HHSC started looking at this waiver, one thing that was really important, instead of just going to the large hospital districts and working with those public funds, they really looked into what could be done in the rural communities and what could we do, in those counties that don't have a hospital district or a public hospital, and really investigated, how does the system work right now? How do local funds work? What's happening with local health care? And so, hello? Can you hear me? Okay. And so I was really thrilled that HHSC really wanted to look deeper and to look at those rural communities and counties to see what could happen. For indigent health care has been around for 26 years, primary care, those programs, and there's always been a concern that there weren't federal dollars involved in these programs, and it's your local tax dollars. So I think it was a real opportunity now to look at what is out there federally. How could you potentially do your programs different than what you've been doing, and to look into that. So in the past, the counties, for the last couple of years that the UPL program's been around, some of the counties have really invested in that and found out that they really could run their indigent health care programs in a more efficient and more cost-effective way by entering into those intergovernmental agreements. So I think, again, looking at this, I think in the past some of the counties that contributed to that did wonder where the money went to when they did go into the intergovernmental transfers, what was happening to those funds. I think this now is an opportunity for the counties, the hospitals, the players to come together and see what they can do on these incentive programs, see where the money's going, what are the projects, what can they do together. And I think it's an opportunity for them to see and work together. Also, I think help with the incentive things. That's the thing I think that we're really looking at across the county lines. What could they do with chronic care? What could they do with preventive health care instead of reactive health care? What could we do together? And I think that's the real opportunity that you're going to have with the impact to the local communities in the counties. I think, again, as Maureen said, we want to look at access, the quality of care, cost-effectiveness effectiveness and the collaboration. You've been out there working together, but maybe in separate silos. So this is an opportunity for collaboration, and I think pulling all of you together in one room, talking about what your regional, what your county issues are, what your local hospital issues are, together really is an opportunity, and that's what we're hearing across the state. Let me say, Maureen's going to say this again, you understand this is voluntary. Nobody's pulling you and saying you have to do this. This is an opportunity. I know that's been a fear and spoken across the state. We're going to have to do this. You're making us do this. No, we're not making you. We are saying this is an opportunity for some federal funds. The $1 billion is certainly some large monies that we can look into and work together on. So that's the impact. We hope that local entities will work together and see what they can do.
So some of the ways that local entities can participate is by collaborating in regions. So that's why we're here today, is talk about invited everybody from this region to come and talk about what the opportunities would be here and to start to talk together. What might that look like with other local entities, hospitals, and other key stakeholders to create regional healthcare partnerships. So that would include academic health science centers who we understand would be able to identify some intergovernmental transfer. So we see them actually as a key player that can come up with some of the funding. And we'll talk about that funding issue a little bit more. But remember I said we have about $2.8 billion last year in UPL funds, and we're going to pretty much double that amount that's available. But one of the issues is that we don't have enough of the state match to pull down all of the $29 billion that's available. So historically, we have about a third of the amount of IGT or state match that we think is available to pull that down. So right now we're talking to people, and as Jan said, letting counties, letting entities with the funds that could be used as match know that this is an opportunity. Again, not to say you have to do it, but to say we've heard over the last 20 years in Medicaid and county indigent healthcare program that, geez, you Medicaid program, you get a 60% federal match on your funding. At the local level, we're paying it with 100% property tax or whatever taxes. Why can't we get some of that federal funding? And so the waiver provides that opportunity if it's something that communities want to take advantage of, given the structure of the waiver. So through RHP participation, entities that do have IGT would identify what hospitals they want to work with, what projects they want to fund, what uncompensated care they want to fund, and what kinds of regional collaborative projects would work. So what do we mean about all that? What are the district programs, and what are the RHP principles? So what is an RHP? Where did that come from? RHP is a regional healthcare partnership. Well, why do we need those? Because in Texas, as we know, we're huge, 254 counties, and so at the state level, we thought if we're working with 254 counties, that's a lot of entities to work with and negotiate and administer a waiver, a funding waiver like this. So we thought, let's get people to work together in groups, in natural communities that work together with patient transfer patterns. And let's try to duplicate that and see if we can get a smaller number of regional healthcare partnerships that would work together. And so we had this idea of forming regional healthcare partnerships, largely, again, around those existing UPL relationships where there's typically there's a big public entity that is having the funding, and then they're working with other entities, private hospitals, or counties working with private hospitals or public hospitals in collaboration. So this is kind of a transformation of that system. Then and the idea here is that we'd also have anchors. Well, what's an anchor? What's up with that? The idea here is, again, instead of dealing with 254 entities within one region, you'd have one anchor. And what we mean by that really is just an administrative entity that pulls everybody together and says, all right, let's get together, let's talk about what we want to do in our community, what our goals are going to be, and what our plan's going to look like. So let me take a minute and just talk to you about the plan, because the anchor is the notion of the anchor is probably important in the context of what a plan is. So how does this whole thing work? So you're in a region. You're in a regional healthcare partnership area number one, Tyler Longview area, or whatever the name's going to be of the region, let's say. And so who are the key players? What are the roles and responsibilities? Who's playing this project? The first thing would be who's got money? Who are the entities that have funding that can be identified for that 40% state match? Because that's what's going to be the first criterion about who can pull down. Remember the 2 lines of credit? That's federal money hanging out there for whoever can come up and meet the criteria, which are 1, state match, 2, you're meeting the criteria about the uncompensated care or about these incentive projects. So the IGT providers, those are the guys with the money that's allowable match, they're key. So think about all those folks sitting around at a table with their IGT money saying, great, we've got money. What do we want to do with it in our region? So that'd be counties, it'd be public hospitals, it'd be hospital districts, probably for the most part, taxing authorities, and academic health science centers as well, who have access to funding that can be used for the state match. So they would decide what they want to do. I'm going to actually whoop ahead a little bit because I think to do this we need to talk about this DSRIP thing. So remember the two pools of money. Uncompensated care is pretty clear. You put that in, you can get money for uncompensated care. And then let's talk about that whole thing that CMS was interested in is let's bend the curve. Let's transform the system. And how do you do that? So how CMS did this, and we borrowed this concept from California because we're working so fast to get this approved from the legislative direction. You used the concept that they had that CMS already liked, and that is let's develop programs and projects that transform the system. And then when hospitals do them, and we'll give them a payment. We'll give them incentive payments. And so we'll flow out money through incentive payments for hospitals when they achieve projects that they say they're going to achieve. And so that's pretty much what these DSRIP things are. Well, where'd you come up with the DSRIP? Delivery System Reform Incentive Payment. It's just we just copied it again from California, just because CMS, the feds were used to it and it made sense. So they had 4 categories, and we adopted their 4 categories. So think of it this way. If you were going to transform a healthcare system, how would you do it? How would you think about doing it, and how would you show what you've done? And so the categories are, well, geez, what can we support? What can we do to support the infrastructure? We know we need more behavioral health. We know we need more primary health care. We know we need more specialty care in our communities. We know we have a lot of behavioral health people going to jail who have behavioral health issues. Geez, if we could provide them with behavioral health before they hit a jail, we'd have a great jail diversion program. What if we worked together collaboratively to create some really good behavioral health telemedicine, telebehavioral health? So these would be the kinds of categories in Category 1, or the kinds of projects, rather, in Category 1, that if we could do these kinds of things, we could really increase the access to health care in Texas and improve the quality of the health care in Texas. So holistic categories here. Okay, so let's go back to our table. So you're at the table, you're a county, you're a hospital district, you're academic health science center with your potential match, and you would say, what's important to the people for whom I have a fiduciary responsibility, my county residents or my hospital district residents or the people that I represent? You might say, behavioral health is a big one. Let's do a behavioral health project. Let's do some primary care access. How would that work? If you have IGT, you might say, I want a primary care expansion. I want to take my primary care clinics. Maybe I've got 3 of them, and I want all of them to go from 9 to 5 to 9 o'clock at night. And so what I'm going to do is work with a hospital. Let's say I'm going to work with the Tyler Hospital. I'm going to say, hey, I've got money. I'm a county. I've got money. Will you guys run a primary care clinic? I want you to expand your hours. Or I want you to run my clinic and expand my hours for me from 5 o'clock in the evening until 9 o'clock at night. Great, they say, we'll do it for you. So I'm going to develop this in my plan. I'm going to lay out a plan, and I'm going to say, whoever you are, if you're a county, give me a county name. Smith, thank you. So I'm Smith. I am Smith County, and I'm going to put some money up, and I'm going to have Tyler Hospital do telemedicine because I know they're good at this. So I say in year 1 of the plan, here's what they're going to do. I'm going to have a contract with them. They're going to contract out and lay all the lines. They're going to get all the T1 lines, whatever it is they need. And they're going to have that done in 6 months. The next 6 months, they're going to start seeing clients. They're going to start seeing patients, behavioral health, telemedicine. They're going to see 50 of them. Year 2, what's going to happen? They're going to increase the number of patients they see by 10%. Year 3, what's going to happen? 10 more percent. Year 4, what's going to happen? 10 more percent. Then Tyler's going to have to send in a report to show, yep, we got our T1 lines, we got the contract done, we got the telemedicine system set up at month 6 in the first year. They send that into the state, and the state says, good job. Now we're going to give you a payment that's identified also in the plan. They're going to go to Smith County, and they're going to say, Smith County, you said you'd give $40,000 to Tyler when they did their metrics, the deliverables. Look, they did them. Give us the $40,000. The state takes the $40,000 from Smith County, goes to the feds, and says, look, they did it. We're taking them $40,000. We're taking that, and we're getting the 60 match out of that incentive pool group of funds, taking it down. We're paying $100,000 now to Tyler. So we went from $40,000 to $100,000 with the match, and now we have a behavioral health system that's identified in the plan. So every 6 months, Tyler's going to do reporting. We're going to see if they hit their metrics or not. And if they did, we're going to go back to Smith County and say, look, met their metrics. Give us your money. We're going to take it up to the feds. We're going to pull down the match. It's going to go right to Tyler. Just change the names and the players. And the same thing would work with the following kind of caveats. Almost always has to be a hospital that receives that payment directly from the state. because it's a UPL program. It's a hospital-based program, so the funds almost always flow there. That's a requirement of the waiver. We're looking at a couple of exceptions about that. So is that a question? All right, let's do a quick question. We don't know yet. So we don't know if there's going to be partial payment. But don't know if there's going to be a partial payment or if they can probably pick it up the next year. So you say, oh, man, we didn't get that contract in. All right, what if you get the contract in at the end of the whole year? Can you get some payment then? So still open question with CMS. But what I wanted everyone to get is this notion of a plan. So in Category 1, here's a series of projects. And what we'll do is we'll create a menu so that everybody who's participating, all the IGT guys and all the entities, performing hospitals. So in that example of Tyler would be the performing hospital. They're doing something, then they're identifying what they've done, their performance, and then they're getting paid. They're the ones doing the stuff and getting the payment. So how this would work, there's the category, the IGT entities at the table figure out how much money they want to put in, what they want done, lay out the metrics for it, and then that's how the funding flows. So let's look at Category 2 projects. So Category 2. So Category 1 was really about access, infrastructure development, more primary care, specialty care. Category 2 projects. So these are projects that an area could choose, and they're innovation and redesign. Like, there's some really good ideas out here. Let's try them and see if they'll work in our area. So some of them might be delivery models using telemedicine, health promotion, disease prevention, medical home models. Let's implement a medical home model. Let's pay someone, or let's provide a state match for somebody to get an incentive payment when they develop and deliver a medical home model, disease registry management. So strategies to impact potentially preventable events. So let's institute in our hospitals, some birth trauma reduction or central line infection reduction programs. Category 3, quality improvements. So this next category, here's the good news, is that hospitals get paid for these projects simply by reporting. So this is just saying, okay, how are we doing in certain areas that are important in Texas? And under this one, all hospitals would report on some of the same two. So the statewide, we pick 2 of these projects. Let's say birth trauma. And let's say central line, hopefully central line infection. Yes, central line associated bloodstream infection. So all hospitals in Texas that participate in the waiver would have to report on that. And the idea is that maybe some of those projects in Category 1 and 2 helped reduce the incidence, the rates of birth trauma and the central line infection. So these are hospital-based programs. And then Category 4, what are these programs? Again, hospitals would get paid just for reporting on these. And these will be programs, actually it's really just reporting on things like it would be maybe a patient survey at a hospital, or it would be certain things like clinical measures based on hospital care that we can trend over time. So Category 4 is really about the Fed saying, how do we know how this waiver has done in terms of transforming or improving the whole healthcare system as a whole, and what hospital data could we look at over the 4 years of your plan or the 5 years of the waiver to see have we really achieved that or not. So those would be the categories of projects that entities could pick from. And let's go back to our scenario now. So remember we said anybody who's got IGT, you're one of the key players in this process. You sit at the table and figure out who you want to work with and which of these projects. I've got 4 categories of projects. Which ones do I want to put funding down? And who do I want to do it for me? What's the hospital that's going to do it for me? And how much would they get, or how much do I have to put up for them to do these projects for me? So let me talk just a little bit about roles under the waiver, who the players are. One player is the IGT entity, the one who's got the money. Another one would be the hospital that's receiving it, doing some kind of work, the performing hospital. And I could be both. I could be like a hospital district hospital where I'm putting up the money and then I'm giving it to myself. Job well done. I'm saying I'm going to do uncompensated care. I'm going to do some kind of project. There's a third entity, and I could also be, as a performing hospital, I could also be a private hospital. What if I'm like an FQHC? How do I play in this game? Can I get the money directly? No, you can't get the money directly. But what you could do is do something with the performing hospital and say, hey, we've got this, we can increase your access to primary health care by doing weekend clinics. Great. And so that Smith County might put money up for Tyler, and Tyler might contract with an FQHC to actually do that. and that would be how I'd reach my performance metrics and submit those to the state. So those are a series of the players. One other player then. This gets me back to the anchor, and that's the anchor. So in this whole deal, what's the anchor doing? Here's what the anchor's doing. They're bringing all the IGT entities together, saying, everybody with IGT, let's come, let's meet. Let's talk about what the state wants us to do. Here's the menu that the state has given us. What projects does everybody want to fund? Let's put it all down on paper. Let's roll it up. Let's do an assessment in our community about the health needs. What's the status? What are the key health issues in our area? What are the demographics? What's the insurance look like in our area? Let's roll that up into a plan, and let's give that to the state as our Region 1 Regional Healthcare Partnership Plan for Texas. So the anchor is an administrative entity, and then it maintains a single point of contact to the state. So does the anchor get all the IGT? Does it all flow to me if I'm the anchor and I, do something with it? No, none of the money goes, none of the other IGT entity monies goes to the anchor at all. So each is, I think, Jan, you talked about this earlier, but each entity that has the money gets to decide where it's putting its money in the plan, writes that out in the plan, and then the state only comes and asks you for your match once the metrics have been achieved. So remember those examples I said, once the metric is achieved, then we say, great, Smith County, you said you put up this money, let me go to you. Doesn't flow through the anchor, we'll take it right from the state. The state will be happy to take it. We'll take it up, we'll match the federal money with it, and then we'll flow it right to Tyler. Same thing with the uncompensated care report. So some hospital will give us its uncompensated care report, or we look at the plan and it says, oh, look, Smith is also giving them money for their uncompensated care. We see how much it was. We go to Smith. Smith said, oh, for them, we'd put up $400,000. We say, great, give us the $400,000. We get the match. Now it's $1 million that we pay to that hospital for uncompensated care. So the money always is flowing in that way. We pull from the IGT provider based on the performance or the documentation, pull from the IGT up to the federal money, match it down to the performing provider. The anchor, it's not flowing through the anchor. Now the anchor's own money is flowing through. The anchor is also a public entity with IGT capacity. So its money is flowing through it, but not everybody else's money is flowing through it. So there's been a lot of concern and confusion that the anchor is going to have undue influence, that's going to get the money's going to flow through it, it's going to get 25% or whatever, and that's not the case. So let's talk a little bit about the money, the funding distribution. We talked about this before. So there's that 29 billion over 5 years, and you can see the distribution. So we are now in year one. The DY is demonstration year. So for the feds, it's a waiver. We're demonstrating something different in Texas. So DY1 we're in. This is where the UPL stays, pretty much like it was. And what you see here is the split of money. Here's the total money by year. And then here's the split in terms of these two pools I talked about, the federal lines of credit between uncompensated care and the district, the incentive money. But you can see that in the first year, most of the money is here. That's because the funds tend to flow in the first year pretty much like they did under UPL, which is largely based on something similar to uncompensated care. A little bit of it is in the district, and that's the funding that would go for planning in year one. But then you see how now more of it's going into the district categories in year 2, 3, 4. So by year 5, it's about a 50-50 split, which means $3.1 billion still in uncompensated care, now $3.1 billion available in those pools each for the program. So that's the money flow and the additional money that's available under the waiver. Let me go back because I brought you to the district category so we could talk about that whole structure and the roles and stuff. So here are the principles. So RHPs, these regional healthcare partnerships, are formed around hospitals that currently receive UPL, and typically one of these would serve as the anchor, typically. Anchors serve as a single point of contact and coordinate the RHP activities and serve administrative functions. So early on in the waiver, we had a lot of people saying, oh, man, we want to be the anchor. We want to be the anchor. And then we said, great. It's administrative functions. You'll be collecting, you'll be bringing people together. You'll be sharing information that might be distributed. You'll pull all the stuff together to report, and you'll submit that to the state. And a lot of people then went, no, we really don't want to be the anchor so much anymore. So the RHP principles, so there will be plans, so the development of these regional plans to address local delivery system concerns. I don't know why I'm pointing. You can read this without the pointing. System plans with a focus on improved access, quality, cost effectiveness. Their RHP regions should reflect delivery systems in geographic proximity. So you saw on those maps, and in fact we've got some copies of these maps if you haven't seen them. Yeah, thank you. I think you've seen them, but in these maps that we developed the maps, and this is really the second draft of maps that we've made. We had another version earlier, and let me tell you about those maps. Again, that's our attempt to say, what have been some of the historic relationships between the UPL program players. And then we've had a lot of meetings, so we did get some preliminary input from people about what makes sense in terms of their delivery systems. And then we received over 150 different sets of input, surveys, and information over this map actually that we put out. And the reason we put this map out is we wanted people to give us feedback on it, on what makes sense in their community. So our executive commissioner's position is that he doesn't want to impose areas on the state. He really wants areas of the state to come and say, look, it makes sense for us to work together. So he wants it to be an organic process that develops locally. At some point, we're going to have to submit to CMS what the regions are. So this map really was an effort to precipitate a response. So people saying, yes, this is great. We're in the right community. We're in the right RHP. Or say, no, this is not great. We are definitely in the wrong one. And so let us know. And then what we'll do is take input from this and figure out what areas of the state look pretty solid, what counties are pretty happy where they are, and where is there a sense of, no, this is not right. Where do we have to focus a little bit more effort before it gets finalized?
I'm sorry. I was just going to ask when you think the different regions will be finalized and a decision will be made.
We're shooting for May, in the ballpark of May, to get regions developed. There was some misunderstanding that the deadline was the end of this month, March 31st. So a lot of people are scrambling around saying, oh, it's this month, we have to start making deals and stuff, and that's not the case. There is a requirement in the waiver, in the contract with the federal government, that we have to send them something on RHPs at the end of this month, but what we have to send them is this document that says, here's how we're going about figuring out what the RHP areas are going to be. That's what it is. It's not the RHP areas. It's here's how we're going to figure out what the RHP areas are going to be. So we've got that well on its way to get to them. And so that's the process we're going through right now. All right, so delivery systems and geographic proximity, that's where we were. Here's an important point, is that any hospital that wants to receive UC or district pools funding have to participate in the plan. So got to be a part of the discussion, the planning, and the development to be able to receive those funds. Waiver funds still go directly to hospitals, so not to counties. Just so everyone knows that. So the focus really has been on the uncompensated care and trying to find ways to more effectively manage the provision of services, again, to bend the curve on cost of care and improve the quality. Stakeholder participation, so this has expanded quite a bit. So RHPs are going to be required to have opportunities for public input and review, and the Commission is seeking, and our Commissioner specifically wants broad engagement, including medical associations, local governmental partners, Department of State Health Services, regional directors, I think Dr. McKay is here today, academic health science centers, children's hospitals within communities, and so forth, and as well as consumer representation. Also, anchors bring together RHP participants and stakeholders together to develop the plans. Participants with match funds select incentive projects and identify the hospitals to receive the payments based on those incentive projects. That should make more sense now. And then participating hospitals will report performance metrics. So that would be the performing hospitals, really. The entity that's doing the work is the basis for getting the incentive payment. Will report their performance metrics and then receive the waiver incentive payments if the metrics are reached.
When will we be required to submit our metrics, like from like a private hospital per se? Because we're coming on that new year in September, which is very close.
Okay, so the plan, the new year will start October of 2012. That's when the year one of the plan or U-tier of the waiver. And so it'll probably be sometime like 6 months or so after that. And so that timeline hasn't been developed yet. But the idea is that when the plan is submitted, then there'll be like a half of a year point where we'll check on performance and then have payment twice a year within each year. So you get quarterly payments now, right? In October. Yeah. So we're looking at the timing now on that. So that's a good point though. So regional healthcare plans, what would they include? A regional health assessment. So an assessment within each community. health status and demographics and so forth, who participate in it, what are the hospitals that are participating, what are the incentives, and what are the projects by district categories. This is important, what they are and what they're not. They do not require 4 years of local funding commitment. So lots of confusion on this one. People are saying, but you require it, you don't require it, which is it? So in the plan, we are asking all the entities to estimate what kinds of funds they believe they'll have available to put up as the match, as that local match. But we know from some of the work we've done with counties since the summer, and from our discussions with CMS, we shared with them that tax bases change, things change, and so you can't know always how much funds you'll have available. So estimate it and put that in, but you're not committed legally to that year by year. You've got your own fiduciary responsibilities. So what else is it not? RHPs do not determine health policy. Early on, there were some physicians thinking, oh my gosh, now these RHPs are going to tell me how to practice medicine. It's not that. They don't do Medicaid policy. They don't dictate Medicaid managed care policy. They don't dictate regional reimbursement or managed care requirements at all. So it's not about that.
Maureen, let me ask. This is your meeting. Do you want to save questions for the end, or do you want to answer questions as we go along?
Let me finish, because I'm almost done.
Okay.
All right? Thank you. They do not. Oops, I guess I am done. There we go. That was a sign from God, I think. All right. Blah, 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 blah. All right, we went through all this stuff. We went through the money, under development, governance structures are under development. But I talked to you about some of those roles. So you got the IGT person, the anchor, the performing hospital, and then the other guys who can subcontract with the performing hospital. Allowable sources of match. We have a document. What can we use for match? We have a document that we distributed broadly to the Executive Waiver Committee. Dr. Calhoun is on that for some input, and then we'll release that. And it's supposed to be a guide. Our goal is that it would be a guide for entities to figure out what is available funding. Project values is another issue. So if we do our plan, let's say we've got $40 million we want to put up for our match. Can we put as much as we want up and say, hey, we're going to put $40 million up for behavioral health telemedicine in Smith County? Can we do that? And can we pay ourselves $100 million? How much is a project worth in terms of value? So that's something that's still under development. Stakeholder outreach. Next steps. Let's talk about next steps. So we submitted to CMS already the UC document, that hospitals will have to fill out to get their uncompensated care. That's in with CMS. March through April, we're doing the preliminary meetings with RHP participants. May 1, RHP regions should be formed. That's our time frame. That's why I want to have the regions formed. August 31st. Here's what's due to CMS on August 31st would be the finalized regions. But you can see we want to get them finalized in May. And then this disparate menu of projects. So we're creating that menu now. On that menu that we're making of the projects, we'll release that on April 1. So that'll be out April 1 for people to look at and see what the projects look like. That's also going to have metrics in there. So standardized metrics that fit with the projects that are out there, so you can look at. And then we'll have it out for a month to get input from people before we turn it around. September 1 is when the RHP plans will be due to HHSC. That's when we're asking for them. And then due to CMS on October 31st. So a couple helpful websites. One is the top one to go check, and we are developing that listserv, so you'll be notified when things change. So keep looking there. And for any questions that you have, you can send them to this mailbox. If you send them here, then we'll turn those around and provide answers. So some of the takeaway points that we think are important right now are that anchors do not control the funding for IGT entities. Each IGT entity will direct where and to whom they want the funds to go based on the projects. Anchors are administrative entities, a single point of contact. They organize the meetings, and they compile the RHP plan. It's not a block grant opportunity. So early on, people heard $29 billion, yay, where do I sign up? What do I have to complete? And it really is about you have to have your funding, and then you have to meet the criteria for one of the two pools of funds. So it's not just like a money giveaway. You have to show up with some of that match. It's a voluntary program, to Jan's point. And Jan, I'm going to ask you for any other comments before we stop, before we go to questions, if you have any.
Not yet.
All right. All right. So, and then all projects must be from the district menu. So look for that April 1 and give us your comments on that, because that'll be important. Why do we have a menu? Because we wanted to have some standardization when we look at the projects and the plans come in. If we can nail the menu pretty well, so you look there and say, yeah, these projects make sense. This pretty much hits what we want to do in our community or not. Then we have some standardization with flexibility, we hope. And then send inquiries here. And I think that's it. Anything you'd add, Jan, from your work with the counties and county indigent healthcare programs, or examples of how you've seen people use this?
what we're hearing around the state, some of the counties are going to work together with their hospitals. They're going to use their local health departments, maybe their nurses, to be their mandated provider or their gatekeeper. Then they'll contract with the hospitals, who will then do the hospital care, and contract with the specialty care physicians, et cetera. Some are going to work on chronic disease management, case management. They're already looking at their indigent healthcare population, and they're looking at how they can help control the illnesses that they encounter. I think the counties are really just trying to look at this. How does this work with my indigent healthcare program right now? So there are a lot of questions, I think, that have come up with the counties. I'm quite sure, from the back of the room, right, Lamar County, I've talked to you quite a few times. So I think you're looking at, does it count, is this takeover, does this meet your statutory requirement for Chapter 61 indigent health care? This does not, this is not a replacement for Chapter 61. You still have the requirement to cover your indigent health care. But is there a better way of doing that? Right now with indigent health care, the law says you have to take care of those people that qualify, that are eligible. But how you do that, you can decide how you provide those services right now under the law. Who's going to do that? Hospital, local health department? Are you going to do that in the county? What's the level you're going to do that? That you can do currently under law. So I think right now it's going farther to see, what all can be included in this waiver. But is really just, it is really going over the mountain, I would say. We're really looking at a different way of doing health care than the way you've done it in the past. So I think it's a real great opportunity.
Okay, all right. So any questions now? I think it's a good time to start the questions.
Start off, and we'll get to everybody with questions. So I'll be on my bicycle.
From the county standpoint, we will need to know in the future how specific the plan will be. Will we be able to offer a certain amount of IGT and not be pigeonholed into certain projects throughout the year, or maybe it would be more broad, such that we would offer a certain amount of IGT and then be able to choose the providers as need be throughout the year?
Okay, so no. So the way this is structured is, so straight up answer. The way this is structured, so here's how CMS is seeing this. It's like, how are you going to transform the care in Texas? Okay, here's a plan. So they're really looking like if you were going to contract with somebody or a consultant or some kind of contractor, you'd say, here's what I want you to do. I want you to do X. I want you to increase access to behavioral health. How are you going to do it? Well, here's what I'm going to do. I'm going to, hire a behavioral health consultant. I'm going to implement behavioral health technology in the first year. I'm going to expand my hours. And so that's what they want to say. Well, who's going to do it for you? Who am I going to pay the money? The feds. Who am I going to give the money to? So that's the degree to which you need to lay stuff out, is who's putting up the money, what county's putting up the money, or what IGT entity's putting up the money. What's it going for? Which one of these projects is it going for? What are the metrics? What are you going to achieve? So how do I know when you did it? How do I know when you, just like you would with a contract, well, how do I know when you did it? What are your specifications? Oh, here they are. Okay, great. I know when I can release the money now. And then in the mind of the feds, these are projects over the 4 years to reach some goal. Whether it's increased access to behavioral health or specialty care, and we'll see that. There are some discussions, and we've heard some feedback about, geez, could we have some flexibility? What if, for example, there's a hospital buyout, and now we've got a new hospital entity? So could we start a new project in year 2, for example? So there are some discussions about that, and we don't know yet. Did that answer your question?
The question was about the flexibility. We don't know that exactly.
Well, no, I would say we don't know about that, but I would say in general, assume what we said. Assume that it's what they're really looking for is what you would look for in a contract. You want to say, here's what I need done, here's how much money it is, here's who's doing it, and here's what the metrics are, how I know they've hit the mark.
Maureen, can a governmental entity decide to just put up money for uncompensated care only, or just put up money for DSRIP only, or they then choose to do both?
Good question. And so here's what we look at this. How fortunate. Here's what we need. Here's the money that we have. Here's the money that we're going to have. So in each year, if you say how much money is in each of these two pools, of the $6.2 billion in year 2, 63% of that, somebody who's good at math, 18, I don't know, 3.6 or something like that, 3.6 billion is going to be in this money. So from a state perspective, we're going to see how much money is in that pool and then figure out how can we best access it. So I think the determination about, like, within an RHP, are we going to ask the RHPs to try to hit these percentages in terms of the money that's being invested, still an open question on that one. But I think from the commissioner's perspective, I'll make a judgment here and say I think he's going to want to see, and CMS specifically said they're going to want to see, they're not going to want to see everybody just using the UC and not touching the district money. They're going to want to see really pulling from both to transform the system.
Maureen, can I follow up with your question in the back? With the counties, one thing I think would be really good to look at is the counties report to us on an annual basis what the top diagnoses are for their clients and what they're spending most of their funds for. So I think it'd be really good to look at, who are you treating, what kind of illnesses, are those some things that you could work with to offset your cost? So it might be helpful to have that.
Well, and Maureen, isn't it fair to say, I mean, you've talked about bending the cost curve, but the real, I mean, we're not necessarily trying to save the world here. What we're really trying to do is reduce uncompensated care. So we need to focus on the things in the community that are driving uncompensated care in hospitals. So that, in my mind, makes it a little more doable than, trying to re-engineer the whole healthcare system.
Yeah, so that is a good way of looking at it, too. Thank you, John.
Hi, Maureen. I'm Richard Carter. I'm the CEO for Hunt Memorial Hospital District in Greenville. I have a couple of, we're one of the 3 or 4 eligible anchors in the Region 1, and so I have a couple of anchor questions. Is that okay?
Sure.
Okay. As an anchor candidate, there's going to be a lot of administrative cost. And let's say that's $200,000 a year or so. What is the funding format or the process for that?
So we're working on that, and know that it makes sense for an anchor to be funded. And so would you put up your own IGT and include that as, say, a district project? So your project might be, I'm managing reporting and quality assessment, data system for the RHP, for example. So we are anticipating that payments will be made to the anchor for administrative function, and just figuring out how that fund would flow and where the local match would come from.
So wait to see on that one. All right.
Lots of waits to see, I'm sorry.
You had, in one of your slides, you had talked about a regional health plan, I think, or something like that. If so, I think that was talking about the community needs assessment.
So here's what that regional health plan is. You get all the IGT entities together, and they each are saying, I'm doing project 1, I'm doing it with, this hospital, here's my metrics, here's what they're going to get paid. So you roll all that up, all the entities that are putting up the IGT, all the entities that are getting the funding, all the metrics for the different projects. That's all articulated. So it's just like, think of it as pretty much a big contract. Who's doing the work? What are their performance metrics? How much money are they going to get when they hit each metric? And who's putting up the IGT for it?
Okay, but my question...
That's the plan, and then an assessment at the front of it.
Okay, so if there is a need for a community needs assessment, are those local needs assessments, or is it a regional needs assessment?
We really want to be flexible, and so we want it to cover the region, but we want you to be able to use the existing assessments that are already out there. So if there's data that you currently have...
Is it a requirement to have a county needs assessment for all 28 counties?
No, we're not that specific, so we really want to get a sense of what the overall community is.
Okay. If there's 28 counties in Region 1, and if one anchor entity is trying to coordinate all this for 28 counties, and each county is doing, let's say each county is doing 3 or 4 projects, that's 100 projects. That's going to be a massive task. And
so what, in terms of administering it?
Yeah, administering all the paperwork and all the reporting and making sure everybody's timely and all that kind of thing. So
here's what we're thinking, though, is that not necessarily that you do that reporting. So what we're trying to work out is get a web-based interface. So if you're the performing hospital or entity, you submit your reports right to the state.
Oh, so it would not go through the anchor?
That's how we're thinking now, is go directly from the performing. We haven't finalized that. So we're trying to make it as simple as possible. So it's just going into the system where we can look at the performance. And then once we see the performance, we go to the IGT entity and say, we need the match, that's been met, and then we do the matching. So the anchor is not involved in that business.
Okay.
But let me go ahead and verify, because I know it's going to be, we're working on the web-based thing, and that's my understanding, is it goes directly from the performing hospital right to the system.
Okay. You had said that you wanted the regions to be decided by May, and that we have the responsibility for voicing our input. Who are you talking has that responsibility, and to whom do we voice our input?
So the responsibility is we've been trying to, the counties, the IGT entities really are the ones that we've reached out to. And so those are the entities from whom we'd like to hear. The input has been through surveys that we've sent out to counties and IGT entities. And the way to get it in at this point would be through this website here now, the healthcare, Texas Healthcare Transformation at HHSC website.
Okay. So is there a formal application or for that, or is it just a, dear Maureen, I want to do this?
We're working on the process for that. So if you haven't, so what we've gotten is different things so far. So we've had some counties pull together and give us a letter and say, we are these counties, here's our commissioners, we want to be in RHP region X, whatever it is. And they'll send it in. And then some people are just sending it county by county and saying, oh, we saw on the map we're with X, we don't want to be with X, we want to be over here, we want to be in this region.
So if I'm the county judge in Van Alstyne County and I want to be in Region 1, they need to be contacting you to be in Region 1. Or if they want to go to Region 9, which is adjacent, they can go to Region 9.
Yes, so we want to hear where everybody wants to be. And we've already gotten feedback from, like I said, about 150 different entities. And can I follow that up? Because what we've done is we're trying to create now a third map. And so that map will take everything that we've gotten so far. And then what we'll do is develop a process for final or formal submission of entities saying, okay, we've seen all the maps now, boom, this is it. We want to come together as an RHP and submit. So we are developing a process for that kind of formal submission, as opposed to where we are now, which is let us know.
There's going to be an application for an anchor to submit as being the anchor of the RHP?
What I'm talking about is really more when you have a whole area together and there's consensus around that, to have an area say, we, the undersigned, we as a group are going to go in and here's our anchor to do that. If you're in an area and you want to be an anchor, that's where you'd let us know and send that into that website and say, we want to be an anchor in our area.
Okay. So in areas where there's a hospital district like in Hunt, Hopkins, and Titus County, which is contiguous with the county lines, who makes that? Is that the hospital district's responsibility or the county judge's responsibility?
To identify who's going to be the anchor?
Or what region you want to be in?
What isn't it the judge? I'm going to look to Jan for a second. Yeah. If there's a difference of opinion, we probably just want to know that and then get that input. So ideally, they'd both be on the same page about where they want to be.
Okay. Well, I was trying to see whose primary responsibility was it?
We didn't identify primary responsibility. We just went out to everybody who's potentially an IGT entity and said, please fill out this survey and let us know, and then we'll get that information back. And if it's, then we'll put out the next. Then we'll have discussions to see what those areas are looking like.
Okay. Thank you.
Yeah.
Hi, I'm Helen Miner from here at UT Health Science Center, and I just wanted to say there are two projects with the Department of State Health Services that will greatly help with the community assessments. The Community Transformation Grant, if your county is involved, and I know of 5 in Region 1, there may be others, but Lamar and Hopkins County, Smith, Van Zant, and Wood County are all involved. One of the requirements is to do community assessment in the broadest sense. And the other is if you're involved in the preventable hospitalization grant that is also county level, those will also give you a great deal of data, so you don't have to start from scratch. And there's a ton on DSHS website.
Yeah, I just want to comment about this particular reason. We're interested in being the anchor too, but this is what a university does, collect all that data. We've been collecting it for years. We have all the data, the demographic data, the epidemiologic data, what the most common diseases are, where they exist, what counties, what problems. We have all that data already. We have a dozen people here who work on that stuff every day. If we're not the anchor, we'll make it available to whoever the anchor is, but that is not something that people are going to have to worry about. That data's available. My people work with Paul's people day in and day out, just tracking that kind of demographic data.
Are you ready?
Yes, sir.
I'm Bill Hale. I'm County Commissioner in Rusk County. Will the contributions from the counties be expected over the whole 5-year period, or annually, or as they want to get involved, or how does that work?
Okay, so we're asking if a county wants to be involved, that they get involved at the beginning. So join the IGT meeting at the beginning of it, and join the partnership. And then we are asking for an estimate of your engagement. So if you want to get engaged at the front end, you need to get in the plan and identify where you want to put money under the plan and what kinds of projects you want to do it. In terms of the funds, when do we hit you for the money? We'll hit you for the money that you say you want to put up for the project when we have the documentation from whoever's doing the work for you that they've done the work. So when we get that uncompensated care report, then we'll go to you and say, hey, we got the report, they did it, give us what you said, and we'll flow it down. So the funding doesn't happen until the performance is documented. Anything you want to add on that?
Okay.
It's my understanding some regions have, L.D. Williamson, Executive Director, Architects Council of Governments. It's my understanding in some regions that they formed an A and a B in a region. So in case we were to do that, have an A section and a B section, or north and the south, whatever you want to call it, would there be 2 anchors? Could there be 2 anchors, one from each region?
That would be 2 different regions. So if there's 2 different regions, then yes, there could be one anchor per region.
So, but if you have an A and a B, it's not considered the same region.
So there can only be one anchor for one region.
So if it was an A and a B, you would just one region, but 2 different areas in it.
We'd still want one anchor for
Just one anchor.
region. Yeah.
Okay.
One plan.
Yeah.
But the plan can be pretty long. Correct.
Well, yeah, and the plan is the compilation, really, of all the IGT entity funding projects.
Hi, I'm Lee Brown with Community Health Corps. Could you elaborate a little bit about the ability to revise the plan? It's a 5-year plan, and I understand you're making an investment and have different milestones, but 5 years is a long time, so just talk a little bit about the ability to make revisions, add new projects, maybe even drop projects. How does that work?
So that's a real good question. So we talked to CMS about this in our negotiations, and we said, can we revise it? Can we have time set in there? Can we structure it that way? California did, and they said, no. And they were very, very firm that we could not go change it. And it was exactly about that point of if you're doing a contract with somebody and the contractor says, yeah, can we revise this at some point, partway through the deal? And you'd say, no, you can't. This is our agreement. And so that's where CMS is coming from on this. We are going back to them, though, and we're trying to identify places where we hope that they will be flexible. So right now the answer is no, and we're hoping that we can get them to agree that, yeah, there are some cases where it makes sense. And let me say this, that we anticipate that in 2014, I guess isn't that case in front of the Supreme Court now? So we anticipate that in 2014 that we'll have under current law, unless it's overturned, that we'll have a need to go back and do a significant amendment to the waiver because so much will change in the healthcare system. So we know that we'll be doing that amendment. But aside from that, what CMS has told us to date is that if you do any changes to these plans, that would require an amendment, which is a big deal in the negotiation of the waiver. So hope that answers it. Let me also say that what CMS has told our commissioner, he's very active. He's like he's flying to Washington. He's not constant, but he's in frequent communication with Cindy Mann at the Centers for Medicare and Medicaid Services, and CMS actually likes this waiver. They've told us they have other states teed up behind Texas to see if they can get something similar, and they really want Texas to succeed. So. They do want us to succeed, and so they said, they will try to be as flexible as they can to help make sure the waiver works. So we're hopeful that where we really can make a good case for flexibility, we can get it.
Okay, Stephanie Raymer, Office of Community Access. I wanted a little bit more clarification on the geographical area of our Region 1. If there is a county And it's my understanding from what you just said, there can only be 1 acre for these 28 identified counties. Is that correct?
1 acre for 1 region.
For one region. Can Region 1 split if there are some counties that want to split apart and create their own region?
So that's what, yes, that would be a possibility. So we would want to
Okay.
hear if there's a split. We'd want to
So how
hear.
soon would they have to get that information to you to do that?
So we should have that information. We probably have that information. I'm hoping we have that information already as we're developing the next map.
Now, another situation I needed clarified, if there's a county from, say, Region 14 that's been identified that does not want to participate there, can they participate in ours, or does it have to be geographically located here?
So it needs to be geographically located. So,
Okay.
yeah.
Because we had several counties that have been asking to cross those lines like that and
So-
asking for statewide.
Yeah, what CMS has said, and I think that's in one of the RHP principles, but what they said is no, geographic proximity. So they don't want the Swiss cheese thing. They don't want,
Okay.
they call it gerrymandering. We don't want to see, up
Okay.
here and down here.
Okay.
If there's concern about the size of the region, again, if we're not the anchor, we'll help whoever is. But we run one program here, we run it in 13 states. We have 2 programs here that collect demographic data, work with counties, local people in 5 states. So it's doable. You do have to build an infrastructure, but it is very doable, and to do it well and to keep everybody together and coordinate it. So, if people want to apply to be the anchor, it is very doable.
Let me just add another thing too. So so you look at this first year and the distribution. Most of the funds are in this uncompensated care pool, and a couple things. One, so we're in this year, and so when we talk about the regional healthcare partnership plan, that will really be a plan for these years, 2 through 5. So really, the plan is a 4-year plan. It might include some of the planning that you've done here, but for the most part, it'll be a 4-year plan for those years. So what in the first year, there's $500 million. This district here, that 12% is about $500 million that's available, and we negotiated it with CMS to have some money in the first year, even though we weren't ready to run with the plans, to have it for the anchors that are doing the work of creating the plan. And what's been decided, our executive commissioner provided the direction that amount of funding, $500 million statewide, will be available. Those funds would flow to the whole, through some kind of methodology that we'll be developing to the partners in the development of the plan. So some people have been concerned, like, oh, man, wait, what about that $500 million? That's now I'm interested in being the anchor. If there's $500 million, that's going to be distributed to all the anchors. And so just to let you know that the idea is not that just go to the anchors, but that the commission will figure out a methodology that's fair. The commissioner will dictate that or direct us on that, about flowing those funds to the entities that are participating in the development of that plan. So that shouldn't be a heat-seeking missile for anchors, for people who are interested in that.
It's probably going to cost the anchor more to do it than having experience with this than you'll make. I've been talking to people, and I've echoed a cautionary tale about splitting the region up, and that is if the region gets split up, you really limit the sources that your hospitals can go to try to generate additional IGT, because the IGT can't cross regional lines. And we're already going to fall short in Region 1. And if we split Region 1 up, we'll lose even more federal dollars as a result. So just keep in mind that Northeast Texas is not that densely populated like a Houston or Dallas or San Antonio. And it sort of needs to hold together so that we can have opportunities for hospitals to find as much IGT as possible.
One of the things that an Academic Health Science Center does, so remember I talked about, I didn't say it this way, but I said there's $29 billion and we only have about a third of the IGT. We need to pull all that down. And so we're working on documents and trying to identify where are some possible sources of this funding. And Academic Health Science Centers are a significant potential source of funding under the waiver that's been untapped so far for the program. So we do see those as potentially bringing benefit to systems.
Yeah, my name is David Cleveland. I'm the Executive Director of the East Texas Council of Governments here in East Texas. I want to give you a hypothetical question, if that's okay. Let's say there's a number of very innovative projects to address various healthcare needs and issues in the region, which we expect will occur, are actually put in place. And at the end of 5 years, some of these projects obviously continue because they're so successful. Is there going to be a sustainability plan requirement to make sure that those projects continue to address those needs after the 5-year period when the federal funds run out?
No.
No?
No. So you might then say, well, what's going to happen to these programs at the end of 5 years? And so what most states do, what many states do, is when they have this kind of funding available from the federal government, is they renegotiate an additional waiver. So to continue that going forward. So, I can't speak for the legislature or, about their direction on this, but that's what many states do. But there is not a requirement now from CMS to say, okay, anybody who's getting money, tell me how you're going to maintain these programs at the end of the waiver. So there's not that kind of requirement.
So if it is successful, there is the strong possibility of continued funding.
If that's the direction to go and pursue a renegotiation, and then we get access to the funds in an additional waiver. You're welcome.
Ken Miller, Paris Regional. I'm concerned about the state matching because the reality is it's not like counties have a lot of money laying around, millions of dollars to throw to a matching fund. So if the state's not going to allow those dollars to be counted towards the 8%, why in the world is the county going to match those funds? I certainly understand every county is concerned about community health, but they don't have the extra dollars to throw at it. There's roads, there's roofs, there's other stuff's going on. So is the state, or would the state reconsider allowing those dollars to flow? Follow-up question is on the uncompensated care. I'm assuming it's going to be paid off the most recently filed cost charge ratio off the most recently filed cost report? Or how are you going to pay that uncompensated care? Or are you going to pay it as we're currently doing the urgent care program?
As far as the 8% is concerned, that's certainly been a question around the state. Currently, the way Chapter 61 reads, which is the statutory authority, the IGT, in the past with the upper payment limit, those were not attributed to the 8%. Now, again, that statute, every couple of, there's a session coming up. If that needs to be changed and someone proposes that bill to do so, they would. Here's one thing I think that to consider with the counties. If right now you're already paying a hospital, it's fee-for-service, right? As you're paying for an indigent person who goes into the hospital, you already have that cost right now. That is a cost you're already incurring. So now it's just thinking about that differently. Had you rather do it as a transfer, as a paying out per client, per pay, as an encounter? So I think that's where you already have a cost. I think some of the counties are already looking to it again. Your jail inmate care, again, the waiver's not taking the place of what your responsibility is. But again, if your local funds could be matched with a hospital, or that could do some other mental health things that would offset your costs that you're already incurring. So I think that's what the counties are having to look at, and certainly it is a question. But the 8% right now, that hasn't, I think our legal counsel is still looking into that, but that was not counted towards the 8% in the past. So it's really a statutory situation as it is right now.
Your other question was, would the state consider allowing the counties, and I think it was to directly receive the funding. And is that right?
Well, the uncompensated care, if the county decides to take their 8% and throw it in the uncompensated care pool, if you will.
Okay.
Is the payment going to be based off the most recently filed cost report, cost to charge ratio? Is it going to be paid as we're currently paying under the indigent care program? How's that going to work? And I guess another follow-up, I'm sorry.
Sorry.
So to your point, Lamar County spends the 8%.
Sure.
So if Lamar County decides to throw all the money in the uncompensated care pool, and they come to hospital, and we say, okay, Lamar County, we'll take care of all of your health care needs. That means the hospital is going to have to contract with physicians, labs, whatever, how does the hospital then turn around and send that back up to the state to get paid out of the pool?
So on the hospital side, so how the uncompensated care report would work is the hospital documents its uncompensated care costs based on its standard Medicaid cost reporting form. So most of the DSH hospitals are already doing this, and Medicaid DSH hospitals are doing this, and so the document utilizes most of the existing forms already, maybe some supplemental forms, but it would document those uncompensated care costs at the hospital level. So whatever the hospital's costs are, that's the basis for the payment from the state.
What about my follow-up question as far as I'm a private hospital, and so the only way I can imagine my county officials are going to pour the money in, if it's not going to count towards the 8%, is if I as a hospital say, I'll take care of everything. I'll take care of your physician needs, your lab, your x-ray, everything. But none of that comes on my cost report. I'll wind up contracting that out.
Right.
So how is that going to flow through this pool if that's what we want to do to get to pull more money down?
So Jan, remember your the hospital, your historical hospital cost example? Remember that one? So here's what I've heard Jan say in the past about this, is that what some counties do is they'll say, oh, we always spend, on average, I looked at my last 3 years, and we know we're always spending $4 million at this hospital for uncompensated care in our county indigent health care program. We know we're always seeing that. And so why don't we can even, just say, oh, let's be conservative. Let's say we're going to take $3 million. So we're going to spend $4 million for this hospital, for your hospital, and uncompensated care costs. We're going to say, let's take $3 million. Let's say we're going to put up to $3 million now under the waiver as our match for your uncompensated care costs. And what that means is you could see, all right, somebody who's good with math, 3 is 40%. 2.5, 6 is, what, $7.5 million? Okay, somebody who's good can correct me, but I think it's about, thank you. So it's about $7.5 million. So now what can happen is you would be able to be paid from the pool up to $7.5 million off of that $3 million transfer. So as before, you might have had some uncompensated care costs that you didn't get paid for, beyond the $4 million. Now you're getting $7.5 off a $3 million match from the county. And so the county might say, great, now I've got a lot more capacity for my residents to go see you and seek care, and you're not going to be running out of money so soon in the year. I'm not going to be running out when I hit my 8% now, because I'm going to have a lot more capacity. I've more than doubled, 250% increased my hospital capacity now.
And I think in the past, too, with the upper payment limit program, some of the counties chose just to use the percent of funds that they historically spent on hospital care. They continued to pay out the physicians, the labs, the x-rays, those kinds of things from the county dollars. But the hospital care, traditionally, counties spend about 55% of their local funds on hospital costs. So some of them are looking at that and just simply under the upper payment program looked at what they spent for hospital care, and that's what they were willing to put up for their match. So I think you have to look at, in all fairness, if you had someone from Lamar County that had a car wreck and they were in another county and you needed to pay that, you do have to consider, again, that you might need to hold out costs for what you need to do under the indigent health care program.
Maureen, if I am a IGT provider and I got money to spend, okay, and we have a program or a project that we think is really worthwhile, how much of that can be put towards things like bricks and mortar equipment? Let's say I want to have a new medical home for County A, or whatever, and it's $1 million to build the building. Or if I want to buy a new ambulance, or if I want to expand my trauma network, or if I want to buy a new fancy lab machine to do glucose monitoring testing, is that eligible?
I don't know. So there has been lots of discussion about the bricks and mortar piece, that this waiver really isn't about building a new wing or building a lot of that kind of infrastructure. It really is more for programs and some infrastructure, but I don't know where that line is. And that's something that we still have to figure out where that is. So I'm sorry, Richard, I can't answer that for you right now.
Other questions? This is your opportunity. Yes. Oh, okay.
Commissioner has one.
I may be the only one in here confused. I want to understand, so I can take it back to my county, the contribution that a county makes can be counted as part of the 8% for indigent health care or not?
No.
I don't think so.
Okay.
I don't think
That's
so
the
at
way
this
I
time.
understood it, but
There
I
was
wasn't-
we still have legal counsel checking, but I will say in the past with the upper payment, the way that transfer works, the way Chapter 61 is written right now, it is the Medicaid rates, and it's per claim, fee for service. So that's not the transfers haven't. But let me help you think about this. If you're not close to spending your 8% right now, and there's a better way of doing business, it still may be more cost effective for you to do something different. If you're close to the 8%, such as Lamar here in the room, they really have to consider what that is to their county and how they would do that differently. But if you're not close to that, I think a lot of counties are going and really considering that there really may be a better way of doing it, to have an incentive plan that would help offset your cost on the front end instead of the other end. And I think around the state, counties are starting to really talk about that and trying to see if they want to engage in doing something different, especially in the district, I would say.
The fact that it doesn't count towards the 8% is state law, correct? Not federal law.
That's correct.
So if it's state law, come the legislative session, the legislature could vote to change that, correct?
That is true.
Okay. There you go.
And Jen, you're, I think, doing a county and local governmental webinar next week?
We are. On Monday, on the 26th at 1:30, I think, there will be a webinar again to talk that's directly for the counties so that we can go over this waiver again.
It's my understanding, though, that if the county's not in it by October 1st, even though the legislature changes that for the 8% would count, they can't get in it. Is that correct for 4 years?
That's right. That's right.
That's what I was going to ask, Maureen. Is that something you could go to the feds and
Yes,
say we
thank
might
you,
have
Laura.
a legislative
Yeah.
change and then get it flexibility?
Yeah, that would be an area where we would want to ask for flexibility. Thanks, Laura. And so we would ask though counties just to get in and participate in the plan front end, get in it up front.
At least you'd be
sure how to
dealing with
handle
the
that.
state legislature and not Congress in Washington, so a little better. Okay. Additional questions? Yes, ma'am.
Jan said there was going to be a telecast on Monday.
A
Where is
webinar
that?
Monday?
Webinar. Yes, ma'am, at 1:30. If you'll look on that, and I think there was some information, I'm sorry, where do you represent? Okay, Rains County. I can send you that information, Patsy, okay? There is, I think HHSC sent something to the county, all your county judges, commissioners about that. I'll send something out to the entities as well, to you.
Everybody understands? Another question. Okay, we're going to get them all answered today. Okay. Okay, Chris.
Chris Taylor, Cherokee County Public Health. Really quickly, give me a piece of advice. If I'm looking at bringing in an FQHC, am I now wasting my time?
Well, no. But I think you heard Maureen talk about that we're talking about on the district end, working with your providers on who might do which one of the categories. If you're going to work on primary care and you need a contractor to help you do that primary care, I think it's where the uncompensated care that's different for the FQHCs, but not on the district projects. Is that correct, Maureen?
Well, I'm just trying to think. You're bringing in FQHC really to help provide some of the services.
Well, for example, in our county, I mean, we've got $100 million in preventative care across the county that could be, folks out of the ER, and I'm trying to work with my hospitals to make that happen. But if now an FQHC is a direct competitor, is what it sounds like to me, then I'm just wondering if I'm spinning my wheels.
And again, don't you think the IGT entity that's making this decision, whoever you're working with, right?
That's you, right?
Right. Well, our county funds my department 21%. The rest is state funds, yes.
So again, as you work on your project, correct? I mean, it's up to you, I think, who you're going to contract with and who you're going to do primary care with, if that's your category of project.
But I would say it is the case that under the waiver, the FQHC is not going to be able to receive funds directly, and neither can a county. And so the entities that can receive funding are going to be hospitals. And so if you foresee doing something with a hospital, that would be a vehicle for you either to pull down the uncompensated care or to do a district preventive health promotion project through that hospital, and the hospital can contract out if it needs to with other entities. But that'd be a way for you to access matching funds and then do services. You just have to have the hospital engaged in that.
Right.
I don't think yeah.
Oh, okay. Right here.
Just quickly, can we get a copy of your PowerPoint presentation?
Yes.
Yeah, we can. If it's okay with you, we can post it on our website.
Sure.
People can print it out.
Sure.
We'll post it on the website.
Thank you, Dr. Calhoun.
And it's on this website. Okay. Okay. An older version, I think, is.
You're welcome to post it.
We'll
Thank you.
Post
that'd be great.
Version on our website. Give us about 2 days.
2 days is fast. We'll have an updated version, but I don't know. It'll be 2 days. So.
All right. Yes, ma'am.
Shirley Fultz, Lamar County, Indigent Healthcare, and County Treasurer. My question is, what we're going to take away from this meeting today that we have a concrete number on or date on is May 12th, we have to decide what region we want to be in as a county. And then by September 1st, we have to decide to go with the RHP. Is that correct?
No, I would say by,
no?
Here's the date. So by May 1, all the regions should be formed. So we want to have all the regions formed by that time frame.
Yes, that's what I said.
Okay.
Yes.
The other one, which one did you say? September 1. This is when the plans will be due. So the plans that the anchor is pulling together with all the IGT entities and the performing providers, that has to be sent in. We want to see that shooting into our mailboxes on the September 1, by September 1.
Okay, but this answers to Jan. Jan, our indigent health care starts September 1st, so therefore, what do we need to do?
That's a hard question, Shirley.
Uh-huh.
Well, I think, again, most of the counties, you do your budgeting right in June and July. You're deciding for the next year. So I think this is the year you're going to decide, if you're going to be involved in IGTing your money towards, a hospital and projects. Is that going to be something that you're obviously going to think about right now? Now, your Chapter 61 responsibilities do start September 1st.
That's right, and since we're out of money, of course, our people's indigents are going to look for us for care. So we have to have something in place and know what we're going to be doing. So, and you have pretty well said the 8% was a no. So therefore, basically, it's going to be left up to our county judge and county commissioners to decide if there's any money to set aside for the hospital. Am I thinking correctly?
Yes, Shirley, I think that's true. I think, again, Lamar County is a good example of right now. They expend their 8%. You're right there at that door. For state funds, state matching funds, they are eligible to draw that. State matching funds have really diminished from 2.6 to 211,000, so there is not much money to match counties. So you're the perfect example of really examining what you're doing now, because Lamar County actually has to close their indigent health care program because you're out of funds. The state will give you a little bit, then you really have met their liability. So I think you're really at the point of examining. You have about 5 months that your indigent clients won't have services, basically, other than going to the hospital, those kinds of things. So you really have to, now this year, you'll have clients that come back in September that could be potentially very ill, that haven't maybe had prescriptions or primary care. So I think why this is a really hard decision for you, it is the time to start thinking about is there an incentive plan or something else that would help offset your costs thinking about it next year? Because I have the same appropriations that I have this year for next year. So still, again, you're at a really crossroads right now determining what would be best for your program and your clients and your community. Did I answer it somewhat? Somewhat.
Can I ask a quick question on that? Just do you know, like, your historical, I don't say, but your historical hospital expenditures? So you could say, oh yeah, we have X as our historical hospital expenditures at each of these hospitals that see patients. So because just thinking about the funding flow, if your budget is such that you would either be paying the hospital whatever the payment is on a monthly cycle, or you could plan that up, and then let's say that the uncompensated care report hits at mid-year at 6 months into the program. That would be a point at which you could potentially make the payment for the services provided by that hospital. So I'm trying to think about how you could time it so you could have the program going and the funds available for that half-year period. But we've been asked to come up with some scenarios for counties, so we're hopeful that we can be able to think through that for counties like you.
We have been at this for an hour and a half. Let me conclude by giving you a little interesting bit of information. Right now, the program is going, and hospitals are receiving payments for uncompensated care. If our region remains configured the way it is on that map, then $23 million, this is our region, $23 million of local government transfer drew down $68 million of reimbursement to hospitals. So the $23 million that was put up by the transferring entities in our region drew down $68 million for the hospitals in the region, just to cover uncompensated care. To my knowledge, there's not been one nickel identified to take care of to cover the additional money made available under the delivery system reform projects. Not a new nickel has been identified to pick up those costs. And so however this region, whatever it is, comes together, that will be one of the discussions and one of the challenges in order to figure out how to do DESRA projects. If I said something incorrect, Maureen, okay. So keep that in mind. With that, please take, I don't know if there are any left, but any of soda pop. Get the cookies away from me because they'll just mess me up. Take the cookies, take a cup of coffee, drive safely, and thank you for coming. Okay, good job. Okay. Yeah.
Thanks for being such a great
Oh, okay. No, it's no problem.